Hello and welcome to Module 4 of the Bigg Elimination Tribute Project for the Building Provider Capacity for Hepatitis C Prevention Program Integration. Module 4 will focus on staging. My name is Jill Wolfe. I am the Hepatitis C Program Director with the Caring Ambassadors Program. And this program was co-created in collaboration with the Chicago Recovery Alliance from a training that we collaborated on in October of 2019. We have since adapted the training to be a module-specific, self-paced online training. We are grateful to our sponsors for their support. As the title of the program indicates, this program is in honor of Dan Bigg, the former executive director of Chicago Recovery Alliance. Dan was a fierce hepatitis C elimination advocate and harm reductionist. We miss him dearly, and it is with his spirit that we develop this training. As a reminder, the overall project goal is to build your capacity, confidence, and knowledge to integrate responsive hepatitis C screening, testing, linkage to care and cure, and support programs into your existing infrastructures. This 7-module series is broken up as such, and we will be focusing today on staging. The purpose of this module will be to illustrate the process and the timeline associated with staging people living with hepatitis C. And to help us with this lecture, we've worked with Dr. Andrew Aronson, Associate Professor of Medicine at the University of Chicago. Dr. Aronson is a hepatologist and gastrointestinal doctor and conducts echo lectures through the University of Chicago's echo program. This lecture, along with the following 2 lectures, are based on his telehealth model, and we will go ahead and listen to him for most of the session, and I will pick back up when he is complete. The objectives of this module, and by the time this module is over, you will be able to identify the steps needed to complete the staging process for people who are living and diagnosed with hepatitis C. You'll also be able to list the resources and the partners that will help accomplish and complete staging workup processes. As with all of our sessions, we will start with the concept of nothing about us without us, and hear from Peter about what we within the viral hepatitis community can learn from the HIV prevention community.
We can learn a lot from both treatment and the advocacy piece. I think that I've been attending some meetings lately where a lot of hepatitis C advocates have been pulled together. And what I noticed about being at those meetings is that the most outspoken and the most active hepatitis C advocates did not look like me, did not come from the communities that I come from. And I really respected those advocates who don't, but I was a little dismayed at the fact that as the way hepatitis C has impacted my community, that there were not more people who looked like me and who came from the places that I came from involved in hepatitis C.
I want to thank Peter for that. I think it's vital that we're including the communities most impacted in the work and development towards elimination. And if we look statistically, this is just anecdotal, but within the baby boomer cohort, African American men who are baby boomers, 1 in 10 of them have hepatitis C. And statistically speaking, about half of those folks don't know it. And so Peter certainly represents a population that we need to hear from and that are absolutely vital in developing services towards elimination.
What is staging? Staging is really what answers the question, how bad is somebody's hepatitis C? So staging actually refers to the amount of fibrosis or scarring, we'll use those terms interchangeably, that occur in the liver when somebody is infected with hepatitis C. Now, it'd be really great if I could tell you if you've had hepatitis C for 5 years, this is how much scarring you have, or if you've had hepatitis C for 10 years, this is how much scarring you have. But it turns out it doesn't really work that way. And what we know is that the progression of fibrosis over time can be very variable. So some people can go 50 years and have very little staging and very little scarring, and some people can go 10 years and have a lot of scarring. There are some factors that we know that will affect this. One of them are those that are co-infected with HIV have a faster progression of fibrosis. Certainly people who are drinking alcohol at the same time when they have hepatitis C have a faster rate of progression. And then other things like if they're on immune suppression or even genetics, both of the virus itself and of the person can affect this. This is really important to stage patients. So why does it matter? First, most importantly, it answers the patient's question, how bad is my hepatitis C? But it also tells us a lot about where they are in their disease process. It tells us what types of medications they can use, how long they'll need the treatment, and it also gives us a lot of information of what kind of follow-up they'll need after the end of treatment. Okay, so this is a sweet graphic courtesy of Jill Wolfe, which I like a lot, and I'll probably start to steal it from my slide decks here. But this really kind of shows what's happening. So hepatitis C causes scarring. Scarring is the same thing as fibrosis, and when that progresses even more, that causes cirrhosis. So this is what hepatitis C can do to your liver. Now this borders on getting in the weeds just a little bit too much, but I think it's important to illustrate what I really mean on a histologic means for staging. Now, this is the only time I'm going to show pathology, but I think it's important. So for those of you that are familiar with the liver histology, this little triangle, this little circle with the 3 dots in the middle, that's the portal triad. That's the artery, the bile duct, and the hepatic vein. And in the middle, in the portal vein, in the middle is the hepatic vein. And this is what we call the portal triad. So when somebody has stage 1 or F1 disease, they just have a little bit of scarring right here in the portal triad. So you can see some scarring here and here and here. In stage 2, they still have this scarring at the portal triad, but then they start to have small little wisps of scar tissue that begin to leave the portal triad. So you can see it's starting to kind of grow. In stage 3, it's the same process, but now those little areas of scarring that have escaped the portal triad now connect. And we call this bridging fibrosis. And this is now what we consider advanced fibrosis. So these are folks that actually have a lot of scarring of their liver. And then finally, stage 4 or F4 is also synonymous with cirrhosis. So all those things mean the same thing. And again, it's the same process here, but these fibrous bands are just much, much thicker. And for those that have seen or are familiar with what cirrhosis looks like, it's sort of a nodular formation of the liver. And that's what we're seeing here is these nodules starting to form with the scar tissue. So it goes all the way from 0, which I didn't show, which means no scarring, 1, 2, 3, and 4 leading through cirrhosis. And people who are infected with hepatitis C are going to progress through those different stages of fibrosis and if they're not treated, will ultimately become cirrhotic. So what is cirrhosis? I kind of showed you the histology already. Cirrhosis can occur after anything, any kind of chronic damage to the liver. So this can happen after alcohol use. This can happen after hepatitis B, fatty liver disease. And for our purposes today, we're talking a lot about hepatitis C, but the physiology is the same really no matter what causes it. It's very key to know that there's 2 different types of cirrhosis, kind of the early stage and the late stage. So the early stage of cirrhosis is called compensated cirrhosis. And what compensated cirrhosis means is that the liver has that scar tissue. So you can see those thick fibrous bands that occur throughout the liver, just like I showed you in the last picture. But if you look at the patient, they look very well. So they're not yellow or jaundiced. They don't have any swelling. They'll feel good. They won't have any complaints. These are people that are compensated cirrhotics. Decompensated cirrhotics are people that begin to have symptoms for their liver disease. And the way to think about this is their livers look like cirrhosis, but the liver themselves kind of can't keep up with the needs of the body. So they develop portal hypertension and start having signs and symptoms of liver failure. And these are patients that are going to look sick. These are patients that have ascites or have had gastrointestinal bleeding or even encephalopathy from their liver disease. So if you're staging somebody and they come in with any of these things that I've shown here, you kind of have your diagnosis. You know that that patient has cirrhosis. So this is ascites. This is accumulation of fluid within a peritoneal cavity. This is jaundice. You can see this person's eyes are very, very yellow. There is some yellowing underneath the tongue, which we're trying to show you here, but probably not doing the greatest job. Varices, this is a picture that's taken inside the end of the esophagus. And when the blood pressure gets very high around the liver, these things called varices can form, which are these engorged blood vessels here. These can be extremely dangerous. As you can see here, this one's already starting to bleed. This can cause life-threatening bleeding. And then pulmonary erythema is reddening of the hands. So you can see that from some of the vascular changes that happen during cirrhosis. And the palms of the hands become red, as the name implies. That's why you call it pulmonary erythema. So if you see patients that have some of these physical signs or symptoms of liver disease, you would have a very, very high suspicion that these patients might have cirrhosis. So how can you do the staging? So those are sort of the obvious cases, but what about everybody else that doesn't have these obvious cases? Like I said, anyone from F0 all the way to a well-compensated cirrhotic is not going to look very sick, and they'll probably tell you that they're feeling fine. Well, one thing you could do to find out is do a liver biopsy. These are still done these days. We do them for a lot of other reasons in liver disease, but in all honesty, these are not things that are necessary for staging of hepatitis C. We have lots and lots of other good tools that we can use to stage patients. So I don't want anyone to walk out of here thinking, well, I can never treat or manage hep C because there's no way I'm going to get my patients to do liver biopsies. In fact, I don't really even think liver biopsies are standard of care for patients with hep C, so don't have to worry about that. There are some lab studies. Some of them are pretty cheap and quick, like the APRI and the FIB4, which we'll talk about, or other fancier tests, super fancy tests like direct markers of fibrosis, which we'll talk about. And then finally, FibroScan, which I want to comment on also, which is a newer technology. It looks kind of like an ultrasound, and it's a really, really great way to measure fibrosis of the liver. So I'll kind of walk you through those just so you can see the different types. Now, some are a little bit better than others. It turns out just like anything else in life, the ones that are more expensive and more involved tend to give you a bit more information. And as I'm going through this, I know we have people from all different clinical settings. And think about the ones that would make the most sense for you in your clinical setting. Not everything works for everybody. That's why I wanted to kind of give you sort of a wide range of all the different things that are available. So we're going to start super, super low tech. So what is the quick and easy thing to use? You can use the APRI or the FIB4. These are great because you really, if you look down at these two boxes at the bottom, you can see the information that's needed for the APRI. You really just need an AST and a platelet count. So we are talking super low tech. If you see a patient, usually if you're seeing a patient for the first time, these are very, very common labs. You're going to probably have these before the guy walks in the door. But if you don't, these are very inexpensive tests to get. The FIB4 uses the age, AST, platelet count, and ALT, so pretty similar. These require a lot of math that is beyond my pay grade, so I would encourage you, unless you have an abacus handy, I would use one of the online calculators. You can find them. Here's the website for one of them. I think we're going to go over some tools at the very end, but the University of Washington Hepatitis C website has a really great resource with all these online calculators. And just like everything else we do in medicine, you just kind of plug in the numbers in the calculator and it will give you the answer. So what are some of the answers that you can get? You can, for APRI, they use a cutoff of 1. And if it's higher than 1, it has a 76% sensitivity and a 72% specificity of detecting cirrhosis. So the higher the number, the more likely the patient is to have fibrosis or cirrhosis. The problem with this is you get what you pay for. So it's super cheap, super easy, but really it's not going to tell you the different stages. So if you remember when I talked about stage 0, 1, 2, 3, and 4, This kind of tells you, yeah, you probably have cirrhosis, or no, you probably don't. It's not going to give you that level of granularity between those. FIB4, the same thing. The cutoffs are a little bit different. You can use either or of these. And again, those are both going to give you, yeah, probably cirrhotic, or no, most likely not cirrhotic. This is a really great tool to use if you are in a very, very resource-limited setting, if you're taking care of patients that really can't get a lot of labs drawn, or they're unable to come back and forth very often. Really, really great to use this, because you can kind of use this as your initial marker to find out how bad their hepatitis C is and how much fibrosis they have. So going a little bit fancier, these are what we call direct markers of fibrosis. So these are also blood tests. And you can see I've listed a few of them here: the fibro test, the fibrometer, the fibrospec, the HepaScore, the FibroSure. There's all these different ones. And you can see all these markers of fibrosis that are measured. These are all proprietary tests. They're each owned by a different company. And they measure things like haptoglobin and alpha-2 macroglobulin and apolipoprotein A1. I don't know what any of those things are, but they all actually measure fibrosis in some way, and you put them together in an algorithm, and they will give you some idea of whether the patient has cirrhosis or not. And these give you a little bit more granularity. Now, granted, this is a simple and easy blood test, and that's great, and you're going to get a little bit more information than you would just with an APRI or a FIB4. So if you look here, this is a FibroSure. I know in Chicago, most of our FQHCs that have access to these blood tests, FibroSure is usually the one that they're able to order. And you can see here it gives you a number between 0 and 1, and whatever that number is going to correlate with the level of fibrosis. So if you got a 0.85 on your patient, you're going to know that this patient is probably an F4 or cirrhotic, versus if you got a 0.1, you're like, oh, that's great. This patient probably doesn't have a lot of fibrosis at all. So really, really helpful. This is a great test to send if you have a patient who, they're in your office and you're not really sure how often they're going to be able to come back, or they have difficulties with access to care, trouble getting a ride back and forth, whatever it is. You have them in your office. You're like, you know what? I want to get as much information as I can about their liver disease right now. Great test, because you can draw the blood, you can get the information, and then make some clinical decisions based on that. So really, really helpful. And then the last thing that I wanted to cover is transient elastography, or FibroScan. This is a pretty creepy picture that we've included, so that will be forever burned into all of your heads. You'll never be able to unsee that. But what it is the reason I put it up there is because it kind of looks like an ultrasound, although it's not an ultrasound. The way that this works is it actually measures sound waves, and there is a little story that goes along with it. It turns out this is sort of an urban legend, but this technology was invented in France in a cheese cellar. So it turns out in France, when you have cheese, the longer the cheese matures, the better it gets, the harder that the cheese gets. So they used to have somebody that would have to sample all these different cheeses to see if they were hard enough in order to sell, and if they would be ripe enough to sell. And obviously that's a very painstaking process to poke all these different cheeses. And then someone figured out that sound waves goes much faster through hard things and slow through soft things. So they said, well, why don't we just fire sound waves through all these wheels of cheese, and when they reach a certain speed, we know that it's hard enough, because the sound is going fast enough, that we can go ahead and start to sell the cheese. This was, really made things a lot faster. Some very, very smart person realized that the same thing actually happens to your liver. So as you get more and more cirrhotic or fibrotic, the liver gets stiffer and stiffer, and that correlates with the speed of sound going through your liver. So this machine is actually just sending sound waves through the liver and measuring how fast those sound waves bounce back and forth through the liver. The faster they bounce, the faster the speed is, the harder the liver, the more fibrosis there is. So this will correlate with how much scarring is in the liver. And this is really, this technology here has essentially replaced people needing liver biopsies. Really kind of a great story, because before, someone would need to have a very invasive procedure of a needle going into their liver, and it's a whole big thing. This is, I'm at University of Chicago. We have one of these in our office. It takes about 5 minutes. The patient just lays there. There's no IVs. There's no nothing. They just put a little piece of plastic on you, take some measurements, and you're done. So it's pretty awesome, and it really gives us a lot of information. And here you can see as an example of what the cutoffs look like. So from anywhere from F1 to F2. Again, this is stage 1, stage 2, stage 3, and stage 4. If you get a reading of 4 on your liver stiffness, you know you have very little fibrosis. If you get a reading of, say, 17, so greater than 13.2, you know that patient is cirrhotic. So this is really a great way of measuring fibrosis. And, again, this is the most advanced technology, so you're going to get much more information. You can actually see the different levels of fibrosis that they have with a lot more granularity. So to kind of finish up with staging, staging is really important because this is really what tells us how far along someone's liver disease is that has hepatitis C. The first thing we want to do is rule out very clinical evidence of cirrhosis. So if someone comes in with ascites and just had a variceal bleed, you know they're cirrhotic. You don't have to do any staging. And then depending on what your clinical setting is and who your patients are and what types of things they have access to, you can do very, very easy things like an APRI or a FIB4. That's going to give you a pretty good amount of information at a very, very low cost. Something like a FibroSure, one of the direct markers of fibrosis, is great. Gives you a little bit more information, but a little bit more costly. And if you have access to a FibroSpect, that's a great resource. I think that, a few years ago, there was maybe 1 or 2 in Chicago. Now there are tons of them. A lot of FQHCs have them. Most big hospitals have them. These are very cheap tests, and we can help you if you're interested in finding some resources, how to find one. And finally, don't walk out of here thinking your patients need liver biopsies, because probably for almost every situation, a liver biopsy is not necessary. All right, so am I stopping here?
Yes. Thank you, Dr. Aronson. Heard a little bit about the clinical pieces from Dr. Aronson on staging. And once you've staged someone and learned what stage or level of fibrosis they're in, we want to start the process of teeing them up for prior authorization, also known as a PA. I highly encourage you to work with a pharmacist, and sometimes specialty pharmacies have more pharmacists that are able to help with prior authorization processes. But this is oftentimes the thing that's going to stand in the way from that patient from getting their curative medication. So just a few steps to walk through is of course, these are for patients who, be it private or public insurance, needing to identify if they have patient coverage through their insurance. And if they don't, if a patient is uninsured, there are certainly patient assistance programs, also called PAPs, directly through the pharmaceutical companies themselves. So regardless of insurance status, there is accessibility to medication, but certainly would be easier with more supports should a patient have insurance. And so as part of this process, you want to determine the eligibility of that person, ensuring that there's no caps for prescription costs. And as part of this, you'll want to obtain directly from the insurance company what their prior authorization paperwork is. Unfortunately, there is not a standard PA paperwork. Each insurance company has their own processes and what they require. And this is something that's important to look through so that as you're sending in your package for prior authorization for hepatitis C medications, that you're including all of the elements that that individual insurance company requires. And so because the hepatitis C medications are as expensive as they are, there is this process of prior auth. And usually prior auth is only used for diseases where there is medication that is more costly or requires specific education, particularly from our pharmacists. And so as part of this, you want to ensure you compile all of the labs. Sometimes this might be going on to, we're going to have the specific links to that APRI and FIB4. There are often times if you have certain labs, you can just use that online calculator and print off what that calculator says and include that as part of your package for the PA. And so then, of course, you would want to fax that form into the insurance company. One thing that might be helpful for you is to review your individual state Medicaid program's prior authorization requirements. This is oftentimes helpful in learning what the specific steps are that your state requires for, especially for your patients who are on Medicaid, which oftentimes have a bit more of some restrictions that you might not see in private insurance. And so I'm, again, using Illinois as an example. This is based off of what our PA criteria is for hepatitis C. And the criteria is that you have to prove what level of fibrosis that individual is in, which may be serologic or might be imaging. And this has changed over time. I know Dr. Aronson talked a bit about what some of those serologic tests could be, specifically those proprietary tests like the Fibro Test or FibroSure or Meter, all of which would be covered by someone's health insurance. Sorry about that. And then you can also do imaging. You can use your FibroScan versus a serologic test to prove what stage, but this is all part of what would be included in that PA package. You want to ensure that the labs are taken within 3 months from the date by which you're submitting that prior auth. And those labs generally, and again, you'd want to check with that specific insurer or your state Medicaid program, but generally will be the genotype, will be a baseline quantitative RNA. So this is ultimately just showing that there is a viral load present for someone. And so the RNA quantity would be the number of their viral load, an ALT and an AST, a CBC, a GFR. For those who are stage 4 only, they're required to have an INR, an albumin, and a bilirubin. You need to also show that there's a negative hepatitis B screening. And that if it's positive, you want to show the quantitative hepatitis B DNA to show that this piece is being taken care of and that their hepatitis B is addressed. Within Illinois Medicaid, we do require a specialist consult letter. I think that many states actually require this, and this is a loophole that is meant to be a bit challenging because there are not necessarily a ton of specialists who see Medicaid patients, or if they do, certainly have limited number of slots. However, we've been able to work with this through our ECHO program, and so I encourage you, if it's not through the University of Chicago's hepatitis C ECHO program, that you do it through your state's ECHO program. But what we're usually able to do to avoid a patient having to go into a tertiary care center and receive a specialist appointment is we allow providers to present a case on ECHO, again, moving knowledge, not patients, and that provider presents that case, and we as a team and Dr. Aronson sitting as the lead clinician, we're able to review that patient and provide that consult letter to that physician who presented. And this really works well around that loophole and that restriction of requiring that patient to see a specialist. A couple other pieces. I've seen this with Illinois HFS. I have seen this with some private insurers, and in other places I haven't seen, where they require a letter of commitment. I will say that there's no other disease state I've seen or worked in where I've seen a requirement of a letter of commitment. And I think that probably this is based on a lot of the stigma that we have around people who use drugs and saying that they are unable to be adherent to their medications, which is untrue. But nonetheless, this letter of commitment, you can find, we'll put a template on our resources, but this ultimately just shows that you've spoken with this patient. This oftentimes came from, at least in Illinois, where they would require a once-in-a-lifetime treatment. And so because of that and those restrictions and discrimination to access of medication, they wanted to be sure that a patient was at a time in their life to be ready to receive this expensive medication. That once-in-a-lifetime treatment has since been removed, yet I oftentimes see this letter of commitment remain. So this could just be a template that you use showing that you've reviewed the treatment and what it means with this person. And additionally, I'd encourage you to go to the Liverpool hepatitis website where it shows drug-drug interactions, where you're able to just put in the name of a medication. And if there are any drug-drug interactions, or even if there's not, I encourage you to print this off and put it as part of your prior authorization package. So just to wrap up with this prior auth pieces, a couple of optional letters or scenarios. While yes, they require that letter of commitment, which is a bit pejorative in nature, here's a couple other ones as well that are somewhat optional in scenarios where you have someone with a known substance use disorder or who has a prior treatment for their hepatitis C and want to make sure that if they're being treated again, that they're able to sign something to know that they will be adherent this time. So these are two situations where, as the provider, you want to be you want to be sure to address some of these, especially for your patients that are in addiction treatment, so that the insurance company doesn't use that as a reason to deny access to care. In terms of the substance use letter, this optional letter literally can just state that you as the provider have reviewed harm reduction practices and treatment, and that this person is engaged in some type of supportive care. And then finally, again, this is just from Illinois HFS. Your state may be different, or the private insurer may be different. But through treatment, the insurer does want to see ongoing lab submissions. So at the start of treatment, which is what we just talked about, they do want to see labs, and mostly this is just viral load within 8 weeks of starting the treatment, 12 weeks post-treatment, and 24 weeks post-treatment. So these are important things to consider based on that individual's insurance. So as we think about the staging process and some of the psychosocial supports someone might need, this is a time where we are finding out how sick someone is or isn't, and doing what we can to tee up this patient to, as easily as possible, actually get their hands on the medication to start treatment. And so during this staging time, this is a variable amount of time based on someone's insurance or living situation. The staging process could take a month. And I've seen other situations where the staging process has taken upwards of 6 months. And so it's really variable. And during this time, you'll really want to touch on treatment history. Has this person received hepatitis C treatment before? And if they have, what happened well or not well to start treatment again? We certainly want to address their substance use disorder, especially as it relates to reinfection. Letting someone know how hepatitis C is transmitted and how it's not transmitted, and that certainly once we get them to cure, that they can get reinfected again, and so helping them to protect their livers and certainly their loved ones. And so this is the perfect time, again, to talk about this transmission and reinfection and how someone can use drugs safely or keep those around them protected as well. This is a time where someone may be trying to figure out how to talk with family members, and especially for household contact, this is an important time to talk about where your family and your partners might want to get tested. We've had situations where, a father found out he had hep C and had just recently taught his teenage son how to shave and using the same razor. And while it's certainly a minimal risk of transmission, there is a risk of transmission of sharing shaving razors and tweezers and whatnot. And so this was an opportunity for this particular person to bring in their family for additional testing. And this certainly is a time to talk about sexual partners and risk of exposure there. We'll talk about this a little bit later in some of our additional modules, but sex, while it certainly is a way to transmit hep C, it's generally a poor way to transmit hep C. And that's certainly dependent on the type of sex that the individuals are having, and if there is the risk of exposure to blood. And so we certainly see that there being higher risk in some subpopulations like MSM, we see an increase of hepatitis C. But again, we just have to look at the context of what type of safer sex practices we're able to introduce to prevent hepatitis C transmission. I think that the timing and the setting of the stage for this successful therapy is really important. Oftentimes, it's going to be much harder to get the medication in the hands of that patient than it is for that patient to actually take that medicine. And so sometimes it's important to spend a good amount of time to go through this prior authorization process. And once that person gets the medication, they may, looking at how that medication can be taken at a time where hopefully 100% adherence can be given. So this is really important for teeing somebody up around medication literacy and health literacy. And again, this is a time to talk about stigma and ensuring that we can do what we can to help a patient understand this disease, what it means and what it doesn't, but also help them ensure their literacy of their insurance and what it means to actually use your insurance well. So this is some vital things to think about as we're supporting patients. I want to talk about a couple tools and resources to point out here. The first one is this AASLD, which is the American Association for the Study of Liver Disease. They have treatment guidelines, which you'll find at hcvguidelines.org. This is vital as we look at what treatment is appropriate for someone given their level of fibrosis, their experience or non-experience with cirrhosis, etc. So this is something that's important to look at. The calculators that Dr. Aronson talked about, the APRI and the FIB4, if you look in the resource section on our modules, you will see we will provide links directly to these calculators, and you will just need to have some lab markers on hand to fill it in for the calculator. I'd encourage you to develop some prior authorization checklists based off of your individual state's their prior authorization requirements for your Medicaid patients. Those are the minimum requirements that most insurance companies private insurance companies will use. But again, as I said before, all companies are different in terms of what they require. So doing what you can to collect what some of these prior auth checklists are from these individual insurance companies and aggregating them to come up with a form will be most helpful for you helping a patient get that in hand. Specialty pharmacy. This is a huge resource. Pharmacists are some of our most, I think, underutilized resources for testing and certainly for treatment and even vaccination. And we're going through this whole process here of PA and prior authorization when really a specialty pharmacist or a pharmacist who might be working with you can help walk you through each and every one of these processes that you wouldn't have to do as a case manager or a nurse or physician on your own. And again, I want to really encourage you to use ECHO, that telehealth model. Pretty similar to what you kind of heard Dr. Aronson speaking, but there's certainly didactic components and case presentations that we didn't include here. But you'll be able to see ECHO programs for hepatitis C and opioids and various other disease states as well. What's changed here is that treatment has ultimately gotten easier. You know, we talked back in Module 1 about who's living with hepatitis C. And baby boomers are folks who've been living with hepatitis C and lived with hepatitis C through a time where treatments were really difficult. And now there are way less side effects and incredibly shorter treatments. But it doesn't mean that it's necessarily easier to get the medications. It's getting easier, but that's still some of the advocacy work we need to do. At this point, there are certainly more treatment options, and the more time goes on, we're able to see these treatments added to the list. We see that treatment is extremely effective, upwards of 98% success or cure rates. We're seeing that there are more patients being allowed treatment access. There are less denials happening at the insurance and especially the Medicaid level. And that these restrictions around insurance have dramatically loosened, allowing for people to get easier access and way less discrimination happening for people who have substance use disorders. We went through staging, and our next module is treatment. And we will be doing that in a similar fashion that this one went. Dr. Aronson's going to join us again for a lecture for about an hour or so. And the purpose of that module will be to explain the treatment process and clarify Hep C treatment goals. I want to remind you to please take your pre and post tests so that you can obtain CEUs or any certificates you might need for your employer. And as always, you can access our tools at any of the individual module pages or on our main page here, and email us with any questions you might have. So thank you, and we'll see you at Module 5.